Hi, today we're going to talk about the guidelines for the care of infants with perinatal exposure to HIV. A couple of goals today that we'll focus in on are, number one, we'll review sort of the guidelines for infants with perinatal HIV exposure. What's their risk of acquiring HIV, and what are the antiretroviral drug regimens that we choose in order to prevent them from acquiring HIV perinatally, and what are the presumptive therapies that we use as well in high-risk infants. We'll also take a look at some guidelines around breastfeeding, transmission, and how to counsel pregnant women on their infant feeding choices. So the first thing you want to do when you are faced with a child or an infant with perinatal HIV exposure is to determine the infant's risk status. And so there's high risk and there's low risk. And essentially, these are new updated guidelines that have come out in the Illinois Perinatal HIV Guidelines. And they determine that high-risk infants are those born to people with HIV who meet at least one of these bullet criteria. So either they did not receive prenatal care, could be that the woman did not receive any antepartum antiretroviral therapy. It could be that the woman only received intrapartum antiretroviral therapy, or she had acute or primary HIV infection diagnosed during pregnancy, or she was diagnosed with HIV only during labor or postpartum, or has an unknown HIV status at delivery, or she received antepartum antiretroviral therapy, but did not achieve sustained viral suppression. And that means an HIV RNA level less than 50 copies per mil by 4 weeks prior to her delivery date. Low-risk infants are essentially all other infants that do not fall into those buckets above. Why do we have those guidelines? Well, one of the key studies out of the French perinatal cohort from Mandelbrot et al. In 2015 really showed that the later your timing of ART initiation, first trimester versus second versus third trimester, compared to before conception, the later your timing of initiation of ART, the higher the risk of acquiring perinatal HIV transmission. So that is one of the reasons why we have our criteria as high risk in the slide before. What are some other reasons that we give for high risk rationale? Well, we also know that giving presumptive therapy early definitely limits the seeding of viral reservoirs and limits the seeding of viral sanctuary sites. So the Mississippi baby was an infant with in utero HIV infection, and that baby was given antiretroviral therapy at less than 30 hours of age. And with that early presumptive therapy, that baby had 27 months of remission, meaning virologic control and suppression without any ART. So we really try to start presumptive therapy, which is a full 3-drug regimen in these high-risk babies because of the effect of limiting the seeding of their reservoirs and limiting the seeding of their viral sanctuary sites. And in general, obviously, smaller reservoirs and smaller sanctuary sites can actually facilitate achievement of remission after the initial start of ART. Some rhesus macaque studies have also shown that if you initiate suppressive ART on days 3 to 14, those are the red arrows there in panel A above, you could actually block the emergence of viral RNA and proviral DNA in the peripheral blood and get reduced levels of this proviral DNA in your lymph nodes and even in your GI mucosal tract, compared with if you initiate ART at later time points, which is what you see in panel B below. So what do we recommend for our low and our high risk babies? So the top row there is what we would give for all infants deemed to be low risk. and that's zidovudine or AZT. And we give that for 4 weeks total. If you're a newborn deemed to be at high risk for perinatal HIV transmission, we would recommend 2 regimens, and each of these regimens are 3 drug regimens. The first one is composed of zidovudine 3-TC or lamivudine and nevirapine. And then the other one has the same backbone, which is zidovudine and 3-TC, but we switch out the nevirapine for raltegravir. And raltegravir is an integrase inhibitor. Nevirapine is a non-nucleoside reverse transcriptase inhibitor. And what we would do is get a birth PCR on those high-risk babies, start administration of these 3 drugs for 2 weeks. And if the birth PCR is negative, you would stop the nevirapine or raltegravir, whichever one you started, and you would also stop the 3-TC, but then continue the zidovudine alone through 6 weeks of age. Here's a table for weight band dosing and milligram per kilo dosing for lower gestational age infants when you want to use zidovudine in newborns. The left column is the dosing you'd use for low risk prophylaxis, and the right column is for high risk prophylaxis. And then here we have the 3-TC or lamivudine dosing guidelines for newborns. These dosing recommendations are down to 32 weeks gestational age at birth, and then they are further categorized and stratified by what the chronological age, of course, is of the infant. If the baby is less than 32 weeks gestational age, we would advise that you would consult the Illinois Perinatal HIV hotline and speak to a pediatric HIV specialist. And here we have the nevirapine dosing guidelines for newborns. Something new in this year's guidelines are new dosing recommendations for infants down to 32 to 33 or less than 34 weeks gestational age at birth. And that's the bottom category there. Prior to that, we did not have dosing recommendations for any infant less than 34 weeks, but these are new guidelines that we have out. And of course, again, like 3-TC or lamivudine, we do not have any firm dosing recommendations for infant less than 32 weeks. So we'd ask that you would consult the Illinois Perinatal Hotline for those. And last but not least, this is the raltegravir dosing guidelines for newborns. Of course, we would not give this in low risk prophylaxis. So it's not applicable in that left column, but in the right column, raltegravir dosing is only for term infants. So the infant has to be at least 37 weeks gestational age and weighing at least 2 kilograms for this weight band dosing. What are some challenges with raltegravir use in newborns? Well, again, this is an integrase inhibitor. It is one of the newest categories or class types of antiretrovirals that we have in our armamentarium today. And the benefits are that it has a high barrier to resistance and is quite potent, oftentimes driving down the viral load quickly within several weeks. So there are benefits to it, but some challenges, particularly in newborns, are that it's very difficult to get these granules into suspension. And you must dose these within 30 minutes of mixing it. The dose then changes again at 1 week of age. So oftentimes you need to bring them in for an extra clinical visit. And it's very difficult in terms of explaining sometimes how to prepare the doses. There's a 20-page instruction booklet on how to do it. It's not that it's impossible, but it does require a little bit more education. And last but not least, it can seem a little wasteful because these are dispensed in boxes of 60 single-use packets. And the infant will often only use 28 packets, and we have to educate the parents quite frequently that you must discard the rest of it. So even if you're using a tiny amount, discard the rest of the packet. So those are a few of the sort of logistical challenges around raltegravir use in newborns. But again, very highly potent integrase inhibitor, which we like in this day and age. So we would reserve raltegravir use for infants born to ART experienced mothers with nevirapine resistant virus. So let's just review. In summary, you want to approach newborns who have perinatal HIV exposure by first figuring out whether or not they have a low risk for HIV acquisition or a high risk. A low risk, you'll give the single drug of just zidovudine for 4 weeks. That's adequate for all cases of low risk transmission. But for high risk, because the infant may have already acquired the HIV infection in utero, you want to give a 3-drug empiric therapy or presumptive therapy regimen for at least 2 weeks. If the birth PCR test, which you would obtain in order to rule out in utero infection, if that birth PCR test is negative, you can discontinue the lamivudine and 3-TC as well as the nevirapine or raltegravir at 2 weeks, but you would complete out a full 6 weeks of zidovudine prophylaxis. What kind of testing and follow-up would you want to do based on whether the infant is low or high risk? Well, in a low risk infant, these guidelines recommendations right here that you're seeing are a little different from what we had just last year, because we've updated these guidelines this year, again, in the Illinois Perinatal Hotline. So you would perform an HIV DNA PCR or an RNA PCR or a TNA, which is short for total nucleic acid, at either 2 to 3 weeks of age, again at 4 to 8 weeks of age, and then again at 4 to 6 months of age. Any infant with a positive PCR or total nucleic acid test should really be immediately referred to a pediatric HIV specialist. You would not wait till the 4 to 6 month time frame. But knowing that a patient could be discharged from HIV specialty care if all of those tests that we listed at those time points are negative. In a high-risk infant, you're going to perform those tests, HIV DNA PCR or an RNA PCR or a total nucleic acid, but you'll do them at different time points. You'll do them at birth, 2 weeks, 4 weeks, 8 weeks, and 4 to 6 months. What I've highlighted here in red are some of the differences that you would carry out in terms of management of a high risk versus a low risk infant. So we've just gone over the timing of the testing, which is different. You're adding a birth and an 8 weeks in the high risk. And then the 2 other things that you would obtain testing wise in a high risk that you would not in a low risk would be a CBC with a differential at 4 weeks if they're still on the 3 antiretroviral drugs. And then you'd obtain a urine or saliva for CMV PCR before 3 weeks of age. What about PCP or pneumocystis jirovecii pneumonia prophylaxis? So PCP prophylaxis is really only recommended beginning at 6 weeks of age for infants with a positive DNA PCR or an RNA PCR or total nucleic acid. We don't recommend PC prophylaxis anymore if the DNA PCR or the RNA or the total nucleic acid that's done at 2 weeks and 6 to 8 weeks of age are actually negative, and if all the subsequent tests, of course, remain negative. If you're at all concerned or in doubt, we would ask that you consult with a pediatric HIV specialist to determine the need for PCP prophylaxis. So what about mothers asking if she can breastfeed? What do you need to know? Well, the guidelines have been changing and have been in flux on this particular topic. A decade ago, there was a unilateral recommendation against breastfeeding. And today, what we would say is the following. There have been lots of international trials to look at preventing breastfeeding transmission. And what you see here are the big trials, the DREAM trial in Mozambique, AMADA, MITRA Plus, and the KIPS trial. And the red box to the right shows what's the rate or prevalence of HIV infection that occurred between 4 to 6 weeks and between 6 to 7 months in each of these trials, where there was a mix of breastfeeding mothers and some had breastfeeding and formula feeding arms. And it ranges anywhere from, you'll see 0.6 to 1.7%. So clearly there is a risk to breastfeeding associated transmission of HIV. Let me talk to you a little bit about the biology of HIV and the virology of it. When it's found in breast milk, we think that it's probably cell-free HIV, meaning it's HIV that circulates and replicates in a cell-free fraction, not bound to the cell. And we do see that measured as an HIV viral load in breast milk. Maternal ART does suppress breast milk viral load. Montano et al. Showed that each 10-fold increase in viral load actually doubles the transmission risk, unfortunately, in breast milk. So this is cell-free HIV that's in the breast milk. Cell-associated HIV is HIV DNA that is sitting around in the T cells or CD4 cells. In other words, in your latent reservoir. There's immune activation that induces the HIV expression from the reservoir, and cell-associated HIV is actually 10 times more efficient in activating HIV from infected cells in milk versus plasma. What you want to know here, Roger Shapiro et al. And his group showed that ART does not suppress cell-associated HIV in breast milk, unfortunately. So the cell-associated HIV in breast milk is not going to be taken care of if you give maternal ART alone. And this is the point that we want to make, that cell-associated HIV could play an important role in breast milk transmission. Some other studies that have looked at breastfeeding women with HIV have shown that subclinical mastitis is actually associated with elevated breast milk HIV viral loads. You can see here on the right in the histogram the levels of breast milk HIV RNA associated levels in subclinical mastitis, and that's higher than in women without mastitis. So when you're thinking about a woman and counseling her as she decides to breastfeed or not, we really want to make sure she understands that any sign of mastitis should be cause for stopping breastfeeding. Roger Shapiro also took a look at maternal viremia in the blood and how it can be associated with breast milk transmission. Again, this is high virus in the blood, not high virus in the breast milk. And they showed that high plasma HIV RNA levels are associated with higher transmission risk. In addition, even when ART sort of renders the plasma viral load undetectable, so you could be walking around with a blood undetectable viral load, you can still have episodic detection of HIV RNA and potentially still have HIV associated breast milk transmission. So exclusive breast versus mixed feeding. Let's take a minute and talk about that. You want to tell your mothers, if they've chosen to breastfeed, that exclusive breastfeeding should be the way to go. You should not do mixed breast and formula. This is because they originally evaluated both breast milk and other fluids or foods, and they found that the risk of HIV transmission when you do mixed feeding versus exclusive breastfeeding doubles the risk of HIV transmission. And Louise Kuhn and her team published in the last decade that disruptions in continuous breastfeeding, whether you mix feed or you abruptly wean and then you come back, all of that raises HIV viral load in the breast milk. So you do not want to do mixed feeding. If the woman wants to choose breastfeeding, it should be exclusive. So what are some of the ways in which counseling mothers about breastfeeding has changed over the years? Well, again, as I said before, we used to have a hard line prohibition of breastfeeding, and we have since sort of relaxed that recommendation and have realized that when you have a hard line prohibiting breastfeeding, you lose opportunities to educate, and the mothers may actually just decide to breastfeed intermittently without telling you, and then we've lost the opportunity to try and do other things to mitigate risk. We really want to try and start conversations around counseling and infant feeding choices early during the antenatal period, so that this is not a question that comes up right after delivery and no one is prepared. We want to keep these conversations and discussions non-judgmental, very open-ended questions like, have you thought about how you want to feed your infant, and allow the woman to sort of give her thoughts. It's good to take a step back and understand the context of why a woman might be motivated to or not to breastfeed. There may be cultural norms in resource-limited settings. There may be a fear of disclosure of their own HIV status, or they may be planning to return to their home country in the near future. And the stigma that is associated with not breastfeeding may be too much for the woman to want to bear. You want to validate her desires, I think, and just educate her about the risk and benefits while still allowing an informed decision. I often start with sort of saying, when the woman asks, what should I do? I will usually start with saying that the only way to eliminate all risk for breastfeeding associated transmission of HIV is to formula feed. That is a truth. And if the woman then is willing to accept some level of risk, then we also let her know what the levels of risk there are in HIV transmission with breastfeeding. And then we come to joint decision-making towards the end of her pregnancy. It's really important that, again, we have these conversations early while the woman is pregnant, and while we can coordinate between the obstetric care providers as well as the pediatric HIV specialists prior to the delivery happening. And this is our last slide. I have for you just a few very important phone numbers and websites for you to visit. On the bottom right-hand corner there is the 24/7 Illinois Perinatal HIV hotline. You can call that number 24 hours a day, 7 days a week, and you will always get someone who is either an obstetric provider or a pediatric HIV provider to answer questions. The top left-hand corner there is the link to the DHHS, or our Department of Health and Human Services national guidelines for the use of ARV drugs in pregnant women with HIV infection. With that, I think I'll close, and I thank you very much for your attention.